The Advancing Ideals in Medicine program, or AIM, was founded in 2003 by a group of residents who came together to reflect on some of the challenges they experienced during training, seeking to promote and develop a program that would advance the ideals which originally drew them to medical practice. Since that time, AIM has grown to include a number of resident and department-wide activities, including a monthly resident seminar and luncheon in humanism and medicine, a robust global health program, research in resident well-being, grant opportunities in advocacy, and this Grand Rounds lecture series, which seeks to bring inspirational role models in the practice of medicine into this setting so that we may all learn from their example. To introduce this morning's speaker, I invited my counterpart and AIM co-director, Dr. Hal Atkinson.
Thank you, John, and good morning, everyone. It gives me great pleasure to introduce our speaker this morning, Dr. Prabhjot Singh. He's director of the Arnhold Institute for Global Health and vice chair of Population Health in the Department of Medicine. The Arnhold Institute for Global Health is a new interdisciplinary institute here at Mount Sinai, and it is dedicated to improving the health of people worldwide by building global partnerships in research, education, and clinical care. As Institute Director, Dr. Singh will align high-potential global and domestic health activities across the Icahn School of Medicine and the Mount Sinai Health System. As Vice Chair, Dr. Singh will lead the development of educational and research goals for population health within the Department of Medicine in collaboration with the Department of Population Health Science and Policy. Dr. Singh was recruited to Mount Sinai from Columbia University, where he served as Director of Systems Design at the Earth Institute and as a faculty member in International and Public Affairs. Dr. Singh's varied and far-reaching activities include global health work as chair of the 1 Million Community Health Workers Campaign, an initiative of the African Union in the United Nations Sustainable Development Solutions Network, as well as local development of City Health Works, a Harlem-based social enterprise. Dr. Singh is also special advisor for design and strategy for the Peterson Center on Healthcare. Dr. Singh earned his PhD in Neural and Genetic Systems at Rockefeller University and his MD degree at Weill Cornell Medical College. His postdoctoral training included a fellowship in sustainable development at Columbia University and an internal medicine residency right here at Mount Sinai. He has been honored as a Robert Wood Johnson Foundation Young Leader, a Paul and Daisy Soros Fellow, a Truman Security Fellow, and term member of the Council on Foreign Relations. His work has been featured in a number of prestigious journals, including The Lancet, The Health Affairs, and the New England Journal of Medicine. Dr. Singh, thank you so much for joining us this morning, and we so look forward to your grand round.
Thanks.
Thank you so much. It's really a privilege and an honor to actually be here presenting Grand Rounds. Last year, I was a resident along with a lot of you, and it's really exciting to be here on a different part of my journey and career. The real opportunity here has been to work with this incredible team, not only at the Arnhold Institute of Global Health, but this medicine department. I was reminded this morning when I received news that Columbia University would be shutting down its family medicine program, its residency, as of the end of this year. And really just struck by a commitment that our system has made to primary care, to population health, and really moving forward in terms of confronting a lot of the transformational work that we have to do ahead of us. To improve all of these systems, but at the same time, a commitment to doing so. And so really appreciated that and glad to be here. So today, what I'd like to do is talk a little bit about designing primary care systems. And it's kind of an odd topic in part because you generally don't think about designing primary care systems like they are IKEA furniture or Lego blocks. And at the same time, we actually do make decisions about the design of primary care systems all the time. And I think it's really been through my work in global settings where I began to appreciate what a diversity in possible designs there are in primary care systems. Whether you're ranging from a Brazilian system, which was featured in the New England Journal of Medicine, a review of it this last year, which features really family health teams with a doctor and multiple nurses and community health workers that go out into the community. Or you're thinking about primary care systems in refugee camps, which are very different. They're very functional, they're very bare bones, they're driven by supply chains and logistics, and yet those too are primary care systems. When you look at primary care systems in context of peri-conflict areas, they have to feature very different sort of functionality. They have to be agile, they have to be resilient, they cannot create large structures, and so they have to essentially be mobile and ability to kind of respond and repair themselves. And when we come to thinking about primary care systems in our own context in New York City, it's oftentimes that we have a received wisdom about what it ought to look like. It's a clinic, it's a primary care doctor, there's a team that we have now over the last 10 years begun to understand is central to the work, and that generally is the overall shape of it. There's a lot of complexity inside of it, but that's the shape of it. And so today what I'd like to do is give you a little bit of a view of how we approach this sort of question at the Arnhold Institute, and work that we're doing in conjunction with the medicine department on thinking about practice transformation in the system with a lot of colleagues here today. So my first job about 10 years ago was to look at UNHCR, United Nations Health Commission on Refugee, camps across a scaled set of scattered conflict peri and post-conflict zones that covered about 1 million people. And my job at that time, and I was a graduate student at Rockefeller who was working at the International Rescue Committee, was to come up with 20 questions. Not 20 questions, am I a rock, am I a thing, but 20 questions in terms of what are the 20 questions you would ask every woman, man, and child as they're entering into a refugee camp in order to do dynamic supply chain, to do logistics and supply chain work. That fundamentally, those 20 questions set the entire design of that system. What it could or could not do, what issues were important, what were less prioritized. And I was thrust in the middle of a really contentious discussion. There were about 10 different departments that were feeding into what should be priorities, ranging from child health, sexual reproductive health, family health, and each wanted at least 15 questions that were essential. And if you did not ask those 15 questions, you were maligning the entire enterprise of those group of people. And so it was my job, and I think it was wise for them to pick a junior person to figure out what those 20 questions were. And ultimately, the system only had the complexity or carrying capacity to answer 20 questions and then do the supply chain and logistics around it because it was a scaled 1 million-person system. And when we think about that over 40 countries, we realize that actually across the Sinai system, we're regularly dealing with 1 million people in chunks of time. So we actually are asking and encoding design questions all the time in how we build and design our primary care systems. What I learned most from that, and what I want to kind of share, is that if you don't ask the right questions, you will not design a primary care system that responds to the stressors people face. It seems kind of trivial, but if you're not starting from first principles, in this context, a refugee camp, the issues that people are dealing with and coming from are more complex than whether or not somebody was able to get diarrheal medication, although that's absolutely central as well. And so there's questions about what is the boundary of our primary care systems? How much do we want to design around them? And essentially, what can we execute upon versus what's aspirational? At the same time, when I worked in Lagos and I visited this area, I saw firsthand that actually people are building their own primary care systems all the time. Whether you are in a slum or you're in a neighborhood or you're in a village or in a town or in rural America, people actually have to assemble their own primary care context, the ways that they're able to manage the stressors outside of themselves and their own health all the time. They either get help from the health system, the formal health system, or they figure it out by themselves, or they don't. And that space between what we end up choosing to call a formal primary care system is the degree of support we're going to be giving to a whole range of people in terms of finding their own way to assembling health. And so an initial premise of the Arnhold Institute is that essentially traditional global health programming, and I've spent a lot of time doing this sort of work, working at the Global Fund or the World Bank or the African Union, for instance, is really about kind of high design. You really you look at the question of whether you're building a maternal child health program for a nation. You're looking at whether you're building an HIV program for a nation or multi-country regions. And ultimately, the work that actually takes place at the ground level in the field in terms of how you execute upon these primary care programs is like looking from 20,000 feet down. It's fuzzy. It's very difficult to see. It's actually very hard to understand what specificity people need, and the refrain that you'll hear in national governments is that let's leave that to local decision making, which is a bit different, which sounds good, but it's also different from saying let's actually provide the right type of specificity and support that people need at the ground level. And so what we'd really like to do in our work at the Arnhold Institute is start anchoring in the neighborhood and village context into the design of care systems. And we'll talk a little bit how we do that. So just as an overview of what we actually do at the Arnhold Institute so that you have a reference point for how to engage with us. I really view our work at the Institute as being almost like a core facility for this system. A core facility, we provide certain skills and technical support that can kind of dock into any specialty area, any clinical area, any issue that where we actually can really add value to the conversation. I've had the incredible fortune to hire and bring on board a top computer scientist from one of the best machine learning and computer science departments in the country, James Fogmoose, if you could raise your hand, over here, who's really helping us integrate multiple perspectives, whether it's coming in from a national perspective, data systems, to the ground level, and looking at how we can cross-leverage information that's coming in from multiple layers. On the care systems prototyping side, which is work I've done over the last few years at the Earth Institute, Dr. Stella Sappho has joined us, you could raise your hand, from Montefiore to help really lead how we end up prototyping and designing care models. And then finally, had the great fortune of bringing aboard Anna Stapleton, you can raise your hand, spent some time at the White House and advisory board company, thinking about how can we build policies, and I don't mean this on a national basis, but even institutional policies that really allow for collective action and co-design of how we end up building care models and care systems. So if you think about these three areas, they're actually fairly analytic, they're generic, they're almost content-less, and that's really the opportunity here. So how would a surgical system fit in? How would a primary care system fit in? How would high-need patient support fit into this context? One great pleasure and fortune of my training here at Mount Sinai is that, very different from my scientific training prior to that point, I really got a much deeper sense of the work it takes to care for people. And I was surprised, as some of you that have been my attendings over the years, to see that it took me, it's always at a little bit of like, wow, it takes that much. It's that extra step, and you have to go further and further and further. There isn't a protocol that fully defines how far you should go in order to take care of your patients. And yet, we build systems that actually do encode those boundaries, and then it becomes very difficult after a certain point, or it's fairly easy if it's inbound. And so when we look at a person like Margaret here, who is an elderly, frail person, we end up sometimes asking some of these questions when we're in our patient interview and our histories, and sometimes we don't. So for instance, miss the last 10 rent payments. You can imagine a scenario where actually a credit card company watches somebody's score start to drop precipitously. And instead of asking, is this a sign of dementia, we end up starting to penalize them heavily and plunging them into cycles of debt. And so we ask ourselves, what is the boundary of where we're taking in histories, where we're taking in information? And we have an opportunity, especially this moment of really looking at the transformation of our health system, to ask ourselves what should be included in the type of information that we use to drive patient care. And at the same time, we're part of places that are rapidly changing. A neighborhood that I've lived in now for 5 years, since I started residency here, has changed enormously in just 4 or 5 years. And yet, Harlem, and this is City College in the background, there was an incredibly powerful article about violence in West Harlem in the New Yorker this week. And it's really interesting to ask ourselves, as we are a system that kind of spreads and stretches over a much larger catchment zone, a footprint than we have ever had before, almost covering the entire island of Manhattan. How much of these issues are relevant and germane to us? How much is too complex? We don't have the right tools, versus we may not have the right tools, but they're essential because we essentially won't meet our own goals as a healthcare system. The lines are more fuzzy than they were even 5 years ago, in part because of kind of cataclysmic change in how we pay for healthcare, which is moving faster and faster over time. Which is just to say that we are in what I would call as a design moment. And we're really asking ourselves, what is inbound, what's out of bound, and then how do we actually stabilize it so we have enough specificity to do our work. And so just to kind of put that in context, we're really looking at how much, when we build our primary health systems, should they be embedded in local context, and how much is that too much? Because there really is a balance here, and it's really important to calibrate. The Institute of Medicine released a report in this last year called Vital Signs for core metrics for health and healthcare progress. These vital signs were built in a way that was kind of largely by committee, so I wouldn't necessarily say that all of them are data-driven vital signs, but they are reflective of kind of a marriage between issues that healthcare systems are facing, which are often largely on the side starting with individual engagement, down to care access and preventive services. And then on the other side, issues that neighborhoods are facing on the other side. And interestingly enough, these issues on the other side are actually significant drivers of poor health status. And these issues on the other side are suddenly colliding with the work on the healthcare side as financial models are paying for value instead of fee-for-service, that they're trying to actually look at how much does it cost to take care of a healthy person over time, even as they experience stressors in their environment. And so you're really starting to see a formal kind of encircling of the issues that our systems are facing. And they're actually colliding in a much more clear way than they ever have before. You would look at an issue like addictive behavior, and you'd say that falls squarely in the public health realm before. And on the other hand, if you've taken care of any patients here in our system or in our clinics that have addictive behaviors, you know that it's inextricably linked to their own care and to our own ability to achieve higher quality outcomes, lower cost, higher satisfaction in your ability to take care of the patient themselves, and then ultimately their own quality of life. All of those four pieces that I just told you are critical factors in how we measure healthcare systems today. Therefore, it makes issues like addictive behavior or overweight obesity inbound in ways that they weren't before. And the question is, are we actively able to kind of integrate them across our systems? Now, I know that we actually have excellent addictive behavior, not to pick on that one alone, addiction programs across our system. There are actually system resources, for example, at Beth Israel and other parts of our system that have actually excelled in this area. And then at the same time, we have to ask ourselves, how much do we actually want to distribute these resources across the board? How available will they be? The same question comes about mental health resources or other sort of social support resources. And so the question is, how do we actually integrate them into our care models? And so what I'd like to do before we get there is actually pick one or pick two and go through the practical exercise of how a group like ours would go about designing or redesigning a care model to integrate a stressor that you end up seeing, for example, in the vital signs. This is a health affairs paper that really struck me. It really spoke to me, in part because I realized during my training that the incredible care that we're giving here at Sinai and in New York State is actually at the highest per capita cost of any state in the country. And at the same time, we're looking at a national picture where a decade of healthcare costs has wiped out any real income gains for the average US family. So over the last 10 years, essentially there's been complete wage stagnation, which is probably the top level issue that we should be discussing on our election cycle looming. And actually healthcare cost growth has wiped it out. Now, there was a lot of excitement about the Affordable Care Act being a mechanism to slow down healthcare spending. And it really looks like today that is temporary, a temporary slowdown, and it's about to pick up and pick up fast. There's a few drivers behind that. One of them, for example, you may have heard about hepatitis C drugs, their costs. Drug prices themselves as a category are about to go through the roof. And there are a whole bunch of other factors that are actually driving cost growth again after this kind of temporary slowdown. And so even though you can kind of look at this article and it was written in 2011 and say, well, we got that because the Affordable Care Act kind of put that into check, it turns out that actually we may actually just have seen a paroxysm of the challenge to come as the healthcare sector moves into being 20% of GDP, potentially 25% of GDP by 2030, and crushes the social sector. So the question that I really was interested in is how can we, I'm missing a slide here, how can we look at two requirements for healthcare systems in terms of design, issues that we know are stressors on both families and populations, population spending burden and individual spending burden, and then make sure that we end up designing systems that end up essentially improving upon that axis without sacrificing the ability to integrate with the others around it. Which brings us to this really important question, which is, what is a care model? If you want to design a care model in order to improve upon a certain axis, you have to have a crisp sense of what constitutes a care model itself. And I would like to kind of walk you through just 10 steps to get to a care model. And you can apply this generally to anything that you're looking at, whether your interest is in kidney disease, whether you're looking at an oncogeneralist model, whether you're looking at various issues across the system. This type of approach to kind of designing a care model is something that it's not developed only by us, but a whole group of people across the country are really looking in depth at how do you end up designing and building care models so they satisfy new sets of requirements that are coming up, especially during this period of transition. So how many people are familiar with PCMH, patient-centered medical homes? So is PCMH a care model? How many people say, yes, it's a care model?
Is there any evidence for it, or it's just a care model?
What's that?
Is there any evidence that it works, or it's a care model? What's the question?
Care model. Care model. All right. And so I've kind of loaded this deck. Obviously, you know something is to come, potentially. And so is PCMH a care model? And when we look at the PCMH, so the patient-centered medical home is essentially a mechanism that we use in our systems, for all that are less familiar, to make sure that patients get more integrated services and care in our system, as opposed to them kind of trying to find different pieces of things. And you can look at the pieces of things that are included when you just look at these 6 items, which are part of the 2014 standards. So PCMH standards are tied to payments, and we improve the requirements in our level of patient-centered medical homes in order to both improve quality ostensibly, but also to make sure that we are eligible for a higher degree of payments. And across the country, people have been essentially taking these requirements and doing one of 2 things with them. One is figuring out how they already are doing PCMH stuff and then checking the box. And then another group of people across the country, far smaller, is taking the opportunity to kind of build a transformational approach to redesigning how they approach patient care in their system. And for all those that raised their hands when you said that you're familiar with PCMH, how many of you operate in a clinic today that is at some PCMH standard? Great. And I see, if you're a resident, raise your hand. Okay, great. So for the residents out there, do you know whether you are inbound, whether you're in PCMH care models and you're following it versus when you're not? Yes or no? So yes, you know when you're in a PCMH care model. Okay, so everybody says basically no. And this isn't just to be cheeky. There's something important here, which is that how do you know that you're in a care model is a great sign of whether or not you know the care model exists. And so I want to introduce two concepts here, which I borrowed from Toyota Production Systems. And I can't pronounce these well, but I will anyway, try, which is jidoka and andon. So what are these two concepts? One concept is that you know that you're in your care model because you know when you're not in your care model. And as a result, when things are abnormal around you in just moments and steps, a way that somebody's interacting with a patient, maybe there wasn't the completion of a care coordination step, that you're able to raise your hand. First of all, you're able to detect that there's an abnormality in your care model, that you can stop what's going on, you can fix the immediate problem, which a lot of us do in our clinics all the time, and then go back to the root cause and address it. Here's the challenge when only one person understands the care model. You cannot see all the different types of abnormalities that are coming up in the care model, because we as people enact and create the care models, as clinicians, as care teams. And so it's not tenable to have somebody that has the checklist of PCMH and says we are in care model territory, and then on the other side have our residents or our clinicians say, don't really know what that's all about. And whether it's happening on a real-time basis, if we're getting there, you need to have some way to be able to really detect that. And then there's a second question, there's a second part, which is andon, which is when you think that there's a problem with your care model, do you know where and to whom to sound the alarm? What's the right level of escalation? What's the right way to be able to say, hey, I don't think this is working correctly? The thing is that that's a deeply challenging question in a very large system, because the latter is predicated on somebody being able to potentially respond and do something about what you're talking about. And that's actually very challenging. You may say, let me talk to my practice manager and fix this issue with the pharmacy scripts or these terrible prior authorizations. They're taking up so much of my time. Here, please, practice manager, fix them for me. And if you don't understand the structure of a care model, you don't even necessarily know that, for example, fixing prior authorizations requires a trip to potentially not only Albany, but multiple other parts of offices of large-scale system design, which is not even within the bounds of our system here. And yet, we don't really know what is a trivial problem that can be simply addressed versus what's a complex problem which requires high-level escalation. And so as we're building care models, and we talk about care models in our system, you always have to ask yourself, one, if you think that you're not in a care model, that's probably a bad place to be. Because you ought to be in a care model where you can understand where things are going right versus wrong, and then knowing how to escalate them when they're going wrong. And knowing when things are improving, being able to measure them and have that feedback. So the idea here is to get us to an understanding of a care model and building one such that all of us in our clinical practice are able to stop and then alert when things aren't going well, and being around colleagues who are themselves trying very hard to build better care systems, being in the position to understand whether or not your supervisor, your attending, your practice manager can actually solve this type of problem or not, or requires greater collective action on all of your part. Okay. So step one is defining the goal. And this may seem pretty obvious, But, you know, if we ask ourselves, for instance, I've been watching as our system has taken a lead role in building, for example, the oncogeneralist model. And as we build the oncogeneralist model, which has really been pioneering work from here and a number of other places, we ask ourselves, what's the goal of this merge? What are we trying to solve or accomplish that didn't exist before? What are we trying to optimize on? And so whenever we're kind of looking at a care model, we have to ask ourselves, you know, what is that goal? And for example, in this example I'm going to give you, we've defined two parts of it in terms of our overall national stressors, which are that we want to reduce population spending burden and individual spending burden. So that's total per capita cost of our care model has to go down. The second step is we have to do some sort of requirement analysis. So how do we find essentially places across our system or across the country that are actually meeting that goal? Now, this is actually a pretty different process than people often look to. They often look to kind of inventing something, whereas we know that across the country there are places that are already potentially higher performing or across our system that are doing things well. So we want to find places where there's real, not just on paper care models, but people are in practice every day doing things that enact the care model in a way that you can detect at a higher level. So I want to share a bit of work that I've been doing with the Peterson Center on Healthcare and a Stanford group led by Arnie Milstein to really look at this building care models that are higher performing in terms of both cost, quality, and provider satisfaction. So what this group did in order to kind of find the requirement analysis, they defined the goal. This is the Stanford and Peterson group. And then they looked at 15,000 practices across the country using databases that we have and sorted them by those that were in the best quartile on payer allowed cost and quality composite. So that means that they looked at those practices across the country, small practices, large practices, that were the highest performing in terms of quality and at the same time the lowest in terms of cost. And then they just sorted the entire country and looked for where these are. And this type of requirement analysis will enable to kind of surface or unearth care models in practice that where at least at a high level they're actually operating in the right way of what we're looking for. It turns out that a lot of the people that were found in this process were groups that they had no idea that they were such high-performing care models. There was a 2-person physician practice in Memphis, Tennessee, that when the Stanford group called them up and said, "Hey, you know, you've won. You know, you guys are the best-performing primary care practice. You know, top 20 in the country." They were like, "This is just how we do our work. This is we have no idea why this is best or not. We had no idea that it fell this high." And I think it's a really important point because there's something important about going in our system from the perspective of delivering high quality care to recognizing explicitly what constitutes high quality care. And that group in Texas or in Tennessee was then able to kind of say, what is it about us that actually makes us high performing? And they had to do their own homework. They had to figure out what was happening around them. And then they started to be able to kind of, over time, pull out elements of what they were doing with the support of people that were actually physically there and watching them as well. The point there is that it's difficult when you're high performing or low performing to actually understand your care model and whether or not you're doing it well alone. Which is why you need a step to clarify what is it about your care model, if you are empirically doing well or not doing well, that are the drivers of doing well or not doing well. So the Stanford team went out to these sites. They went with site visits, and they basically spent a couple days there in all of these sites. And they pulled out of them features of high-performing primary care. Now, if you're a primary care practitioner in this room and you look at these features, you're going to kind of say, like, you know, deeper relationship with patients, expanded width of responsibility, leverage the team, not the assets. And there are kind of 10 high-level issues that were really driving high-performing primary care. A couple of them we're going to follow a bit more closely as we go deeper. Responsible insourcing. So what does that mean? It means that, for example, when you have the opportunity to do a knee injection, for instance, you have an option. You can either, as a primary care doc, refer them out, or you can do it right there. When you have the steroid injection. And so we have a lot of choices that come up during our day about whether we refer out or deal with it there. Dermatologic issues, for instance. And responsible insourcing was just a conscious practice to make sure that all of the practitioners were trying to do the most responsible insourcing possible that was safe. Now you may ask yourself, this only works in a system where you have specialties that aren't driving revenue on one side, where you have where the overall system essentially isn't going to lose because of your responsible insourcing. There's all these nice things that you want to do with your patient. What was interesting about these practices, and I think it's a critical point to hold on to, is that a lot of them were actually in fee-for-service environments, fully fee-for-service environments. A lot of them were in practice groups that had specialty care. So you might say to yourself, how is this possible? Let me give you an example from a partner of ours upstate at Crystal Run. How many people have heard of Crystal Run? Crystal Run realized that as they were going through their practice, their primary care practice, whenever they saw a patient with high blood pressure, they would give the patient a follow-up visit and say, and to be really conscientious primary care docs and say, come on back in 3-4 days, let's just check your pressure and see how you're doing. And yeah, stop by and say hi. The nurse will do it, but just swing your head in and I'll let me know. They'll let me know when you're here, and I'll just come out and say hi. What they didn't realize that on the other side, the coming in was a major burden on the patients. The transportation costs were high. They had no idea that just another check-in, depending on the insurance that the patient was carrying, could actually be a big deal. They had no idea. They were trying to do good work. And they went through and they actually got rid of those visits, those follow-up visits in that way. And they noticed something interesting. First of all, quality went up, per capita costs went down, and then revenue went up. The entire practice revenue went up. So what's that about? So if you cancel those visits, why would revenue go up all across the entire practice? Any ideas, guesses? This is like a little logic puzzle.
Fewer hospitalizations.
What's that?
Fewer hospitalizations.
Fewer hospitalizations? It's possible, but not in this case. It turns out those visits were blocking higher value visits. So those follow-ups were actually reducing throughput in that clinic. And when they got rid of those extra visits, patients were happier, providers were ambivalent, they were fine, as long as they understood, as long as they felt assured that the patient in fact had better blood pressure control. There's other ways to do that. And then they found that actually they were able to see higher value visits, the overall practice, and revenue went up. And so I just want to point out here that these are not just, hey, this would be nice to do, and wouldn't that be nice if we didn't live in a world where our specialists, for example, were able to just have higher fee-for-service billing and no way that we do these sort of things in our system. These actually took place in systems where there were a whole range of financial models. And what this gets down to is the power of having a care model that you can actually improve and watch over time that has many different features. Because they interact in interesting ways and lead to higher performing practices. But at the same time, you have to really have a sense of the full design of those systems. So it's not enough to basically look at these and say, okay, what does it mean to close the loop with your patients? You actually have to go a layer deeper and make sure that everybody at a high level understands this across the practice. So this is the idea of, are we inbound or out of bound on a certain feature? And so we look at actual descriptions of what does it mean to have these features here. So for example, when we look at they insource rather than outsource some needed tests and procedures, there's actually kind of specificity there in what it means. And your practice would actually have to go through and figure out what constitutes responsible insourcing in your environment, given your skills of your faculty and your clinicians, and what constitutes irresponsible insourcing. You'd have to actually do that work, and then ultimately together kind of understand whether you're getting there. And so there's more descriptions here. The point isn't so much the details of the features or the rightness of what Arnie was conveying, but that there are descriptions that are simple and crisp enough that everybody should be able to kind of understand, whether you're inbound or out of bound in that context. The next, you need to actually integrate other factors. We are in a busy system with lots of simultaneous initiatives. And so if you say, oh, this would be wonderful to do Arnie's stuff, but let me just tell you what else we're doing at our primary care practice. We're doing PCMH standards, we're looking at LEAP standards, we're looking at other core quality metrics, we are looking at a whole bunch of other issues. You actually have to go in and actually start figuring out what are you talking about in terms of why it's better, and how does it actually relate or interact and overlay with other requirements in the system, of which there are many. And you separate it out. What constitutes white space, partial white space, fully covered by other things you're doing, but maybe not necessarily executed in the same way. And that forms the basis for how you're actually going to go about doing the work of the redesign. Next is actually designing a change package that gets specific enough that it means something to your actual practice environment. And this is something we've already done with our teams. In a very kind of, I think it's pretty exciting that the Peterson Center on Healthcare will be picking 3 national sites for primary care transformation across the country for various reasons. And it's very likely that Sinai will be one of those sites. It's not entirely a coincidence since I also work at Peterson. But it's something that we've already, as teams, started to look at. So for example, we had a day together when we looked at the change package around responsible insourcing, or around all of those features, and looked at across our 80 practices in our system, how is it possible to take what are high-level features and care models and then actually start to build them in ways that make sense to our own practices. And there's a lot of modification that has to take place. You have to co-design it with practitioners and the providers themselves, and actually then test them further. So we had a great session with Stella Sappho, Roy Cohen, Roy, hands up, head of our Primary Care Institute, Ed Young, who's in our informatics group, and Kash Patel, who does our enterprise architecture, to look at what would it mean to kind of look at a full thickness redesign on elements of responsible insourcing. You can't do any of this work in a system of changing these sort of things without having support from finance, from management, from practice managers, from providers, from your clinical teams, ultimately some partnerships with patients so they know what's happening or changing. So there's a lot of what we call full thickness change that needs to take place, and that means that there has to be alignment all across, up and down. At the same time, there has to be enough specificity in what you mean by any one of these features in order to be able to track it in your system. More than that, you have to be able to kind of reconfigure and play with it, because it will not come together in the same way in any one place. And yet you still want fidelity to its goals. And so this is very simple. We kind of look at what is needed in terms of inputs. And this, for example, is a question immediately you can kind of ask your system and say, are we committed to doing this, yes or no? Are we committed to actually paying for physician support and admin time upfront to be able to do this redesign, yes or no? Are we going to do the training? Are we going to look at the costs associated with, not with new equipment, but for example with temporary dips in revenue, because you're going to try to do something different? Are we willing to do that? If not, we are not committed to moving forward in this type of process. If we are, we have a conversation about what can be done next. And so in here, there's a degree of specificity when you're starting to encode these care models, which actually pushes us to ask, are we committed or not? And oftentimes, it isn't just a yes or no question. It's a question of building out the business requirements or building out the case. So why would you do this? Other people at different parts of the system will want to know, what's the plan? Are you going to do this across 50 places, across 30 places? What's the total cost? I understand that the idea of this is to actually reduce entire cost of this care model, but what's it going to take along the way? When are we going to see results? What do we do if there are problems? What if we do if things don't work out well? And so there's a lot of troubleshooting questions that once we kind of understand all the people that are involved here and start asking them and figuring out who's involved in actually constructing a care model, we're in a much better position to be able to kind of move it forward. the next thing you need to do, and this is something that happens at a system level, not only at a practice level, is actually start mapping the inputs and outputs on the system. And this is really where rubber hits the road in terms of what are the actual metrics that we're going to be tracking, the smallest set of metrics that we're going to be tracking across our system. This is basically where you know as a provider whether or not this care model is working for you or against you, because this is the scoreboard. And so, for instance, if you see things that are just saying, only looking at, for example, utilization and there's nothing else on that grid, then you know that this is going to essentially, it's there to squeeze efficiencies out of the current system as it stands. So the scoreboard basically allows us to take a look at ways that we can look at data sources and track in small cycles and small analytic batches what's going on in the system that you're trying to redesign. One thing that we'll be doing and building out across this unit is actually a financial unit that can actually give you real-time insights into how things are changing. It turns out that as a system, we don't actually have that type of asset, around, period. Somebody can say, I'd like to understand whether I'm doing a better job on a per capita basis, on a time-derived activity basis, on other ways across our system, and we can't really fully tell you that. It's a lot of guesswork or modeling or delayed information, but being able to get to this kind of real-time or close to real-time financial information and what it looked like to redesign or reflow a system before you decide to execute upon it is really important information to have. And then there needs to be ways to kind of track whether you're headed there or not. And so part of what our group will end up doing in collaboration with our IT groups are actually building kind of short cycle dashboards that allow a provider, practitioner, or practice to be able to kind of watch how it's doing things and then tinker with it and kind of understand whether or not the care models work, installed, one, and working as a second question. And so then here we get into the short cycle testing phase. And here, this is really an opportunity to say what's missing. So for instance, in the care model that I showed you, the goals themselves that were defined at a high level don't, for example, integrate, for example, the need as you come into our practice space and our patients for a much higher requirement for example, mental health support. What do we do with that? Is it just lopped out of the care model, or do we end up integrating these factors into it? And so these are opportunities, if you just look at the kind of red area, to basically identify major gaps that are only visible either as a function of what your practice composition is like, that need to then be integrated into the system so that that can also be tracked and supported. And then this is a step that usually doesn't happen, but it's really important. Not all practices are the same. Not all patient composition bases are the same. And so when we even look at kind of going from Beth Israel to Mount Sinai to St. Luke's to about, again, 20 other network sites and practice partners, we actually have to understand for ourselves what is the allowable or calibrated variation in that system. How many of you have been following the conversation about readmissions, whether or not they should be adjusting for socioeconomic status? So there was a CMS guidelines a few years ago stating that every single system should have basically the same readmissions penalty. And systems like ours argued that, you're penalizing safety net systems. And the kind of argument was, let's not hold safety net systems to a lower standard. And let's actually push them to do the same work that we'd expect anywhere else. So there's kind of outrage on both sides, right? So one side said, how can you put a lower standard for low-income populations? And then on the other side saying, you have no idea what the work is here. We actually need an adjustment for this system. The ruling stood as it was. It was a flat ruling. And it still is the case, actually, that it's a flat ruling on readmission penalties. But over this last year, there's been a flurry of work that's basically shown that there has been actually a selective detrimental impact on safety net systems, especially public systems, and that actually includes our patient bases. And so if we don't actually calibrate for variation inside our care models, we actually will end up squeezing them in ways that lead to lower efficiency, lower performance, much lower provider satisfaction, and ultimately much worse patient outcomes and care. And so that's also work that we have to do ourselves and provide guidance elsewhere. finally, what is not quite finally, but what's the learning here? We're an academic medical center. So this is a pithy slide because we're still in the process of building out our learning systems. But basically, here's the gist of it. In lieu of a graph, I give you a cartoon. And ultimately, this sort of work is very much around formative assessments, so formative learning. And formative assessments are essentially built to improve program design, to improve performance, and then elements of how that care model is operating. And then a summative assessment allows us to kind of say, cut, this is now a care model that is something that we want to share and move around either the country or within our systems. This is work, by the way, that ends up being, we're seeing on the kind of national basis to be of great interest. See lots of pointing? All good? Okay. Of great interest. This area of how do we build and design care models that can be transported from one place to another is becoming kind of a central question on the health policy landscape as well. And then finally, I'll leave you with doing this. I've given you one feature in one care model. And if you zoom out, we have a whole bunch of other priorities. But the idea of doing things one at a time is that you end up discovering what is needed in order to support the doing of this work in general. So for example, if you work on 2 features in a care model, you'll probably learn what is required to support 10 features. If you end up doing work on 2 care models, you'll start to discover that you need to regularly go to IT, that you regularly need a group of physicians that is your supporting or champion group, that you regularly need certain types of management and patient interactions. And so the idea here is that if we want to actually look at how do we take one small boutique body of work in one setting and then spread and scale it across the system, we actually have to have the kind of enterprise architecture available to do that type of work. The nice thing is that we have it available. It's not always calibrated to our provider and practice-based needs. So that's a lot of the work that this group will be doing. Just to give this a bit more color, the idea here is that we're actually building out the kind of analytics and learning work along with Niyam Gandhi's group, who's our Chief of Population Health. We're looking at how do you spread across our integrated system, which is work we're doing with Jeremy Bowl and our Chief Medical Officer. And we're looking across our network development, how do we work with our network partners, change agents like our residents and faculty members that can actually drive and understand what is both the research opportunities but also the practical opportunities in kind of building these care models. And that's stuff we're going to be doing with Dr. Murphy's Department of Medicine. I'll leave you with this comment, which is that from somebody you may be familiar with, which is Dr. Paul Batalden at Dartmouth, who we work with every so often. Every system is perfectly designed to get the results it gets. It's kind of an empirical statement, but every day when we're kind of doing our work and we're putting one foot in front of the other, that is precisely what creates everything around us. And so if you can't tell in that step what is going right or wrong around you, then we will end up recapitulating the systems that we end up saying, why is this like this? Why can't we do better? And it's really an opportunity to kind of say, what are we doing as trainees, as faculty to kind of redesign those systems? And this is work that I think all faculty members here are doing on a regular basis every day. And finally, the last note is just to say that I gave you an example of 2 features, and they're not complete. And this is not the full scoreboard of issues that are necessary. This is stuff that our system has to kind of work through and really think about what are the set of priorities that we want to look at that are both on the healthcare side as well as on the community metric side. And then we can go about designing that, the type of care models we really want to see. You may say, if you've been in the system for a long time, we've heard this, and this is not the first time a young, excited person has conveyed that there is ways to do things that leverage the great work that's already taken place. But it is also a different day. We are actually in a period where financial incentives are aligned in a very different way in our system, and there's a huge challenge of how do we actually make sure that the system operates to take advantage of them, and then takes advantage of them and moves forward. And so it's kind of a stutter-stop place that we are right now. But I came here and to join Sinai in part because I really felt that this was possible and it was the right time. So I'm really excited to do this with all of you, and I'd love to hear your thoughts and questions.
Congratulations on your courage to embrace this difficult area. My question has to do with older patients. As you know, Sinai has several geriatric programs. And as you also know, older people, though representing only 11% of the population, or 12%, utilize about 35 to 40% of the health budget. So your buttons that don't show age or aged, I wonder what your thought is about this.
Yeah, so I mean, these aren't the buttons. This isn't the console for our options. I think one thing that I've seen, which is really what's exciting about it, fundamentally a young person entering a system, is that we have incredible depth of experience in all these areas around us. And so, for example, Linda DeSherry, hands up, everybody knows Linda, is a national expert in building out how we approach geriatric, frail elderly patients in a different way. And the question then ends up being, how do we take that deep content knowledge and those systems of knowledge that are very specific to that population and end up building care models that are kind of ultimately supportive in an underlying way for a mix of other types of populations? So the short answer is yes, it's a special group. We know that nationally. And there's a lot of work going on right now to understand what are the care models that support them best. That work is actively being done in our own system. And that's something that we are going to be in the position to when we start to articulate what is the full suite of care model that type of work entails, is something that we, instead of importing from Stanford or elsewhere, will be able to kind of share beyond. But there's a huge bunch of steps. I think about it almost like a car wash. You got to figure out what is the right population to support, what is the care models. That's work that's actively taking place right now in our system. How do you make it something that we can spread and scale across our system? So how does it end up, how is it crisp? How can it be reconfigured? All these questions about how can the number of people that can do it expand? And then there's questions about how generalizable is it outside of our context. And so that's a whole stream of work, and we are kind of at the leading tip of step 2, as far if that's accurate. And then there's a couple steps to go after that. But I think it's exciting work, and it's an important area.
One last question. Yeah, thank you. It was beautiful talk. Inspiring. But are you going to look in the Sinai system, compare the clinics with the FPA, because it seems we have like a two-tier, care, like it's so different what patients can access in one and the other system?
Yeah, so I'd say one is that we actually don't have a full analytic view of our populations in our clinics, and that's something that we're going to have to build before we can start asking kind of the drill down questions about how we're triaging and arranging our clinic bases. And I think when we have real data to be able to make surface, what are the optimal ways to configure our system, then we'll be able to answer those questions better. I think at the outset it looks like what we all see, but they're also fundamentally different patient populations, and we have to ask ourselves, how do we want to configure this type of care?
And actually speaking to that, when you look at the models of care that we're talking about, it's not necessarily true that one is better than the other, because both actually are probably not configured appropriately.
And
So we're looking at...
And especially it's because, at least in my patient population, many times they toggle, they have insurance, they don't have it, go faculty practice to the clinic and back and forth. So.
But here's a thought. I know that it rubs the sensibilities to have populations separated, especially high-income, low-income populations. There's also a question of if you essentially need to provide very particular types of support services for a population, are all clinics configured to provide those services? And the answer is probably not. Same thing, for example, for frail elderly patients. They're not going to necessarily be taken care of as well in a clinic that takes care of those patients all the time versus a heterogeneous, egalitarian, every population enters sort of place. Same thing that we see on our hospital floors. That's why we put, for example, our GI post-acute recovery floors are better places to be than a general floor, depending on the issue. So these are issues we're going to have to kind of look at from a data perspective.
Okay. Thanks very much.
Thanks.